Hello, Carol would like to start, please.
Good afternoon, everybody. This is a meeting of the Health and Wellbeing Board of the City of York Council. I'm Councillor Carol Runciman and I'm Chair. And I'm very pleased to welcome all the participants, whether they're in the room or whether they're watching at home or whether they watch afterwards. I'll just do the complicated bit first. You will see that we apparently haven't got anybody taking the minutes. Except that Angela Bilby is online and she's done something awful to her foot. But because we are running out of people at the moment, she's taking them remotely. And I've said if she gets stuck, she can either look at the recording or she can contact me or the person who said whatever it was that was incomprehensible, and we'll straighten them out afterwards. The previous minutes, however, got swallowed up somewhere in a mix-up with ModGov. So there was a technical issue. So they are online, I understand, and they will have to come on paper to the next meeting. So we've got minutes indigestion at the moment. We're doing our very best. I think there's only one other minute taker and they're in another meeting, which is downstairs. The room change also caused a lot of confusion. And I'd like to thank Richard for making it possible because I really cannot hear in the snow room. I can in here because there is a loop. And that makes, for me, that makes the world of difference. So I'm very grateful to the technical people who pulled out all the stops and have made this possible. So any declarations of interest that aren't already on the list? No, okay.
I'm throwing this one in as a wild card because it's going to come up to a point I'm going to raise about the health and well-being strategy around women. I perhaps ought to declare that I am a woman, and therefore I'm probably going to make my intervention with some degree of bias, but I think we're such a large proportion of the population that I hope it won't be considered too much a personal interest.
No, I think it's a personal interest to all, whether they're men or women, but there you go, thank you. We do have some apologies. Perhaps, Tracy, you could go through them.
Okay, so the known apologies we have are from Councillors Waller and Councillor Craghill, and we have also got apologies from Dr. Emma Broughton. I think they're the only ones we know about.
Thank you. We have no public participants, as I understand it. Is that right? No. Okay. So we go on now to agenda item 3, which is the draft joint and health and wellbeing strategy. And Peter, you're going to present that, aren't you? Thank you.
Thank you, Chair, and good afternoon, everyone. So I'm going to speak for just a few minutes and then we can have a discussion on this important strategy. So people will probably be aware that health and wellbeing boards have a few statutory duties, and one of them is to produce a health and wellbeing strategy. The current York one was signed off and approved and published in 2017 and runs out this year. So this is an updated strategy, a new strategy for the city around health and wellbeing. And I'm obviously not going to talk through the whole thing. There's a lot of words in it, but just going to cover, I think, the major points that I'd like to draw out and then invite comments on it. The first is just to go through just sort of page by page in a way what the board will be signing up for if they approve this in September's meeting when it comes finally. The first is the forward and introduction, which would be written by the board themselves. So as the board members, it will be very helpful to have highlighted anything you'd like to amend, change or add to that as it's coming directly, I guess, from the board as members. There's some items on the context for the strategy, specifically looking at how this fits in with two other key plans for the city, which are being published at the same time, the climate change strategy and the economic strategy, and how it fits into the 10-year plan for the city. That helps us explain why we've taken the 10-year approach. It talks about COVID, and it talks about reforms to the health and care system too. It talks a bit about our challenges and feeds on the joint strategic needs assessment for that section, but then also talks about our strengths as well, and talks about the things in the city which tend to good health and makes the balance between the challenges and strengths. It talks a little bit about how we produce the strategy. So it does cover how we have done some public consultation and some engagement, and how the board themselves have been involved through workshops. And this is really what I want to cover, it talks about some specific communities, it talks about some specific ambitions and some specific goals. So first of all, it talks about our big communities, we're calling them, the WHO, 4 groups in our population, and how good health is built up over the life course. So you'll see here that they map quite similarly onto our last strategy with one amendment. The first is that children's health in York will be the best possible health it can be. They'll get the best possible start in life. Secondly, adults with equal access to things which produce good health. Older adults flourishing in an age-friendly city. And then finally, whenever they reach the end of life, people in York die well. And you'll see on the diagram a little illustration of how, whilst people's life course is in some ways the same, in other ways people take different journeys through life. And we know that people develop minor health needs earlier and then complex health needs earlier if they are exposed to more economic and socioeconomic deprivation, fewer opportunities, significant trauma, and those on the opposite end of the spectrum in the city and nationally and internationally will experience a different course through life. So we wanted to make that clear that we are, as a board, going to take that approach across the whole of life, not miss a stage out. But we also make the point in the strategy that people don't just exist in those boxes, they also exist in families, geographical communities, and other networks. So actually, it's not simply about viewing it through these 4 lenses, but also the way that they connect together. The second thing, the board will be asked to sort of give their feedback, comments on our 6 big ambitions. They're the sort of dreams we have for the type of healthy city we want to build. The vast majority of the language in here was taken either from the board workshop or from the consultations that we've done with the public. We're talking about becoming a health generating city. So that's very much focusing on the assets that we have and how we grow health. We're talking about making good health more equal across the city. So that really is about inequality and social justice. We're talking about prevention and having a city which is, well known and recognised for preventing ill health rather than dealing with its consequences later. We're talking about starting things younger, so concentrating our efforts where we can on the youngest, because we know the earlier you're able to support people to live a more healthy life, the better their life will be for the rest of its course. We're talking about working to make York a mentally healthy city, and we're talking about our health and care system and building a collaborative health and care system. So those are the ambitions. And then finally, covering the big goals, because we wanted to put something in the strategy that was tangible and measurable, aware that this strategy won't and can't attempt to cover everything. In a sense, the strategy is a sort of peg to hang other strategies and work off. It is a framework at quite a high level for other plans to roll from. So, there may be bits in this strategy that don't get covered, but that's because they're covered elsewhere in other plans for the city. However, we did want to have some things that we put on a page and say, actually, we're going to measure ourselves against this and we'll know if things are going in the right direction. These were, again, coming out of work that we did to engage people in the production of the strategy, but also from a public health evidence base and from a needs assessment base as well, because these things are essentially the things that lead to early loss of life, early illness, and inequality in loss of life and illness. So the overarching goal, the first one, which we essentially hang above the door of everything we do, is to reduce the gap in healthy life expectancy between the richest and the poorest communities. And 10 years is probably not even long enough for us to really make a huge dent in that. But actually, we might expect to see some shift in that, because actually over the last 10 years, sadly, we actually have seen real shifts in that, and they have not necessarily been positive shifts. And I won't go through the rest of them because they're on in the paper, but 9 other measurable ways that we can know that we're making some kind of difference and setting some goals with some numbers in, some tangible numbers. I'll pick out one around smoking, and the reason we chose 5% for all population groups is because it's a commitment we've already made in the tobacco control plan, and it's a national evidence-based commitment. But the other ones similarly have justification underneath them, and we can discuss if we so want. So what's next? We're going to take some comments now. We'd love comments across the whole of the summer, really. The idea is this comes back to the September Health and Wellbeing Board as a final copy. It's then designed and given a bit of sort of graphic design, and then published and disseminated. We also have a public consultation running on it, and a scrutiny process that has been looking at this along with the other strategies. And then finally, after that, probably the work starts and coming up with a delivery process for the strategy. It's high level, so we need to have action plans and an outcomes framework, which will draw from my previous slide. How do we do those action plans? How do we make them really tangible? Not 79 actions that don't get done, but maybe 4 or 5 actions that do, because they're really clear. How do we do that yearly, bi-yearly? That I think will be the subject of a subsequent conversation, but that probably is the thing that comes next. So I'll hand back to you, Chair, and we can have some questions.
Thank you, Peter. That's very clear. And action plans will follow, of course. You'll see on page 17, right at the bottom of the page, that we need your input. Each organisation has been asked to give us one example of how you could support the strategy. And we can have those now, or we can have those later. So I'm going to ask Sharon, because she knows about these things. How would the City of York's public health team support the strategy?
I'll answer that in a minute, but if I have a comment on the strategy as well, please, Chair. I think we might have had this conversation already, Peter, but for other colleagues' benefit, the graphs that are on page 5 in the strategy, page 9 in our papers for today's meeting, I'm not sure how helpful they are. I think the message that those graphs is trying to give is really important. You know, the fact that we've had life expectancy has stalled and indeed has gone backwards in some cases is a really important message. And I just wonder if we can think of another way of being able to explain that using a graphic, but not such a busy diagram, because you know, those of us who are used to interpreting graphs will understand what that means. Although even with my glasses, I'm struggling to read it because it's quite small. But whether we can work with the publisher to come up with a different sort of graphic that would convey that same message, but make it more accessible for people to understand, I think that would be really helpful. And I know we've touched on that before, but for the benefit of others. In terms of what City of York Council Public Health are doing specifically, if I can think of just one example, public health lead on the development and delivery of the statutory functions of the Health and Wellbeing Board. So we drive the development of the health and wellbeing strategy. We lead and drive the development of the JSNA, the Joint Strategic Needs Assessment, and the Pharmaceutical Needs Assessment. Obviously, that work involves a wide range of partners, not all of whom are around this table. But we very much drive that to make sure that happens and that there is engagement around those statutory functions. So I would probably identify, there are many other ways that we support, but I would support that as probably being the main one.
That's a very good starter for 10. Thank you very much, Sharon. Zoe Campbell's just joined us from Tuve. Thank you very much for coming. It's good to have you here. You have to leave at 6:30. Okay. Now, any more comments or questions? I have to say that diagram on page 9 with all the little bendy straws on it is has got writing which even I, with my nice new lenses in my eyes, can't read. Right, yes, sure.
Sorry, I wasn't expecting it to make a funny noise when I pressed it, so sorry about that. I know we will be talking about accessible information a little later, but I did want to kind of remind us that as a city, a long, long time ago, we committed to providing information in bigger print. So when we do this, when we go out to consultation, one of the things that enables many more people to be able to read and engage with things is using a font that's equivalent to Arial 14. I know RNIB guidance is actually Arial 12, but that's for people with a diagnosed sight loss. So for many people who don't have an actual diagnosis of sight loss or visual impairment, Arial 14 means they can engage. It also just makes it feel a little bit friendlier. I don't know quite why. It just, when writing's bigger, it feels warmer. So I know that's probably a sort of very technical point, but I think it really helps people. Other than that, I really like the way it's written. I like the fact it's not short. I know I've just made a suggestion that's going to make it longer, but not more wordy. So hopefully that's helpful.
Thank you, Sean. Yeah, I think that's very useful. Thank you. And no more little tiny fonts right underneath the grass. Yes, we have Janet, and then we have Simon, and then we have Alison.
Thank you, Chair. I can't help when I was looking through this particular paper, particularly when I was looking at the wider determinants of health. And on page 10, what helps you to live a happy and healthy life? The obvious answer that came back to me was linked very much to a resolution we took at full council last week. And that is having enough to live on, having a house to live in, having not being scared as to whether you are going to be able to eat tomorrow or whether you're going to be able to put the heating on. Okay, we aren't today worrying about heating, but believe you me, we will be worrying about heating a little further down the line. And it seems to me that we gloss over. I look at what helps you live a happy life, and it says being able to go for a walk in a park. Well, that seems to me to imply that you come from a very nice, comfortable lifestyle where that is something that helps you function. It isn't choosing whether I can feed the electricity meter or buy a hot meal for the children. It isn't about whether I can pay the rent or, and I really do think we have got to recognise poverty. The 10% of children living in poverty, and this is getting worse. It is not going to get better if we just, and as I say, the council did take a resolution to do what it can, though obviously our opportunities for dealing with it are limited. But I think we have to recognise that that is a huge determinant of health. If you are warm and well fed and comfortably housed, you are going to be healthier than if you are not. And if your children are not worrying about what their parents are worrying about, they are going to be happier and healthier. So I really do think we've got to recognise that this is something critical. And the other one I did want to throw in, as I perhaps hinted, it seems to have been hitting the headlines just very recently, so perhaps it started hitting the headlines before you wrote the report. But some of these inequalities that we're talking about are actually very gender specific, some of them. Women, certainly the poorer, more deprived areas, are actually living a much worse healthy lifestyle. And again, I do feel that perhaps we ought to recognise that women are a particular significant group within the health and you can't just lump them in with male white middle class people, which, so I am, but I do want to flag those two up.
Please,
as-
can I ask Peter, where did they come from?
The graphs, you mean, or the? Where did what? Sorry, I beg your pardon, Chair. Where did what come from? The
little sticky things. Where did they come
those
from?
bits. Yes, those are from the public engagement. So those are the feedback that people left on the boards that we asked the question: what helps you live a healthy and fairer life? Sorry, Councillor Cry.
So they didn't come out of your head, Peter.
They didn't come out of my head, no.
That's what I wanted. Yeah.
But we can certainly make a really good attempt. I thoroughly agree. I mean, today we've got the publication of the Women's Health Strategy. One of the things it mentions and puts right at the front is that actually women's life expectancy in the UK is lower than nearly every comparable OECD country. So there's definitely I think ways that we can work that into a strategy like this, because I think when we say inequality, we often make the assumption, and perhaps we need to make it clear, we're not just talking social and economic inequality, and we do try to make a bit of a sort of a point about ethnic inequalities here, but we probably ought to also talk about gender inequality, so we can probably bring it in at that point.
Thanks, that's really helpful. Simon.
Thank you. I like this. It's simple, it's clear, it's coherent. I think it's important that documents like this are short, actually, because they're meant to be consumed and absorbed by not only the public, but partner organisations across the system. This is I've got two more points. My first point is an ask, really. I do hope that we ask the constituent member organisations to take it through their respective governance structures, because I can see how this aligns with some of the strategies and plans that we have as a foundation trust within the health system. That's point one. But point two sort of runs a little counter to giving one example about how our organisation might contribute, and more focuses on the sixth big ambition. So it sort of ties into some of the changes that are taking place within the health and care system, where we obviously have a York alliance, and it's important that all of this thinking aligns so that this document becomes a centerpiece for the health and care alliance, and that we think collaboratively, i.e. building on that sixth ambition that we have about how we're going to make a difference and progress the 10 sort of targets that we've identified. I'd be happier seeing that as the ask for the system than asking each individual organisation to say, well, I'll do my bit for smoking or for alcohol.
Yes, Simon, I think you've given us your one, because you said you'll take it to your board and you hope everybody else will. Yeah. And quite frankly, that is so fundamental that I'd like that to go in as the example that you've given. If that's okay. Right, Alison.
And just to echo what Simon said, so many of these goals do supplement what's in our strategy as well. So loneliness, mental health, and health inequalities runs through everything we're doing at York CVS these days. And Peter's always down at our place, aren't you, Peter, talking about it? I just two comments. My statistic for child poverty is 1 in 4 rather than 1 in 10. So can we just check that data? There's obviously different sources and different measurements, I'm sure, but I normally go with the 1 in 4 because it's more alarming. Also, the goal 10, which is about carers, reducing loneliness in carers. I just wondered why specifically it's carers, because we've got a lot of loneliness going on, and could we perhaps expand that and look at different ways of measuring? I'm assuming it's a measurement thing, but I think it needs to be broader than that.
And if we could just cut back on that, Jay, absolutely. I think that's probably the one I was thinking in this discussion we're going to need to relook at. It's carers and it's social care users, so it's both. And but we probably need to find a better way of understanding social isolation and across the life course, not just thinking about one particular group within there, and work from what we want to do and then find the measure for it, rather than working from the measure and then working with finding what we want to do. So I'll take that feedback, and I think we'll refine that. And when we come in September, it'll be sort of changed.
Thank you, Alison. That's a really important one. I've got Jamila and then Lisa, and then I'm probably going to draw it to a close. So Jamila next.
Thank you, Chair. Just two brief points. I really do like the document because I do like short documents. That because my first question to everyone is, who is the document written for? Is it for us as an organisation, or is it for people? So it's quite good because I like that at a glance. So the strategy at a glance is really helpful for the population. The one point I wanted to make, and I think we probably want to maybe tease it out a bit more, is about your point one around life expectancy, because I always sort of say, like, we're looking at life expectancy, and it's and we need to do something in York to bring us in line with others, but equally it's how healthy people are as they get older, and the life expectancy, because what we don't really want to support people to live quite longer lives, but then longer unhealthy lives, and that's sort of counterproductive as well. And it's about just teasing that a bit more out in there. I know you mentioned the word healthy, but it's about how we can explain to our population is that we want to increase life expectancy, but what needs to be healthy alongside that. And then my second point is the mental health, because even when you look at a glance and some of the statistics you brought up, in everyone, there's an impact on mental health around life expectancy, how you feel, loneliness. You know, sometimes people may, I'm just going to generalize, may smoke because they feel low in mood, and it's all those interdependencies. So I'm really glad a colleague from CHUV has joined, because I think that's something that when you do your action plan is going to major on all those elements. Thank you.
Thank you, Jamila. I don't think any of us would disagree with any of that, but that's important points. Lisa.
Thank you, Chair. I really like the strategy, so thank you very much for the time and effort that's gone into writing it. I think the infographics really work, so the more information we can put into infographics rather than words, and back to Sian's point, if actually there's more information that can be easy read, it makes it easier for people to engage with the document, so very much welcome that. I suppose my question, and it is a question about the 6 big ambitions, is do they have equal weighting? Because we talk about prevention's better than cure, and the element of those 6 big ambitions of the prevention and the collaborative working as a system, I would rather see an emphasis on us preventing upstream harm. And there still has to be an emphasis on reacting to health and well-being in the community. But if we can prevent that harm in the first place, I think that would tease out some of the massive benefits that we've talked about living a healthier life in the city. But other than that, I will feed back from a North Yorkshire Police perspective, and to Simon's point, take it to my Chief Officer team. I think it's a really good concept of having it out there in the senior leadership team. Thank you.
That's great, Lisa. Thank you very much indeed. The organisations that haven't had a chance to speak, and this is rather a pressurised meeting for which I apologise, hopefully you'll send a few well-chosen words when you're ready. That would be very much appreciated. Send them to Tracy or send them to Peter. It doesn't matter which, does it? No, thank you. I think Sharon's going to do an update on COVID for us.
Yes, I am. I just got a short presentation to get up.
Apologies for some technical issues.
While we're waiting for the presentation, oh, there it is. You might be wondering why COVID is on our agenda today, but I think most of us will be aware that COVID is still with us. The pandemic isn't over. And even though it might not be widely reported in the media, and many people seem to think that, you know, COVID is gone, we don't need to take any precautions, we can just go back to living life as we were before COVID. Those of us who are still living with the impacts of COVID day to day whether that is us personally, our families, or our services. And I'm sure I've got a slide showing admissions to hospital, Simon, so I'm sure you might want to say something at that point. So it's still very much with us. So this is why we've got the update today. So we haven't really got accurate data on testing and the true incidence of COVID now since the wide availability of free COVID testing ended in March. So we rely on ONS modelled estimates to show us what we think the prevalence is in York. The data on this slide takes us up to the end of June, but actually the latest data really shows that our prevalence in York is around 5% of the population, which is very similar to other parts of the country. So we know that your likelihood of catching COVID is certainly increased. There is still some testing going on. So when we talk about the validated rate, there are still some people are still doing, some members of the public are still doing their own tests and reporting those results. Obviously, people get tested in health and care settings. And so this gives us a more accurate picture, I suppose, of people that are accessing services or who are being tested for COVID. And as you can see from this slide, York at the moment has the highest rate of COVID in York. I would add a bit of a public health warning to this figure, because we know that our population in York is more likely to test. We have very high uptake of COVID testing throughout the pandemic. And we know that some people are still choosing to test. And so that might account for why those figures are so high. So we just need to understand the context to that. When we break that down then by age groups, as you can see, there is COVID in all age groups, but we've got the highest rate in adults, kind of in their 30s and 40s really is where we're seeing the highest rates, which isn't that surprising. The latest subvariants of Omicron, BA4, BA5, don't seem to be affecting children hugely. So we are seeing increased numbers in adults who are obviously being exposed to infection in the workplace and in their social context, etc. The rate looks high for older people, but when you look at the actual numbers of cases, they're relatively low. As you know, we always pay attention to what's happening with COVID in people over 60. Again, you can see our rate in York is slightly higher, but again, that just might be due to the more testing going on in our area. So broadly, we're in line with the England and regional averages once we take that into account. What we can see is that hospital admissions due to COVID is increasing. So this isn't just patients who have gone into hospital for other reasons, been tested and found to have COVID. We're seeing more people go into hospital with COVID. The data I have for today, Simon, which I think is the most recent, is that on the York site, there were 76 patients in general and acute beds and 3 in ITU, is the data I have for today. But obviously, York site is still at Opal 4 and is still incredibly busy. So I don't know whether you want to add anything at this point.
I actually don't have the number for York. I have the combined number for York and Scarborough, which was around 134, 35 to today. So that number is probably right for York if you look at the differential between the two. We are astonishingly busy at the minute. The combination of COVID, and of course there's COVID sickness as well. So staff absences have started to grow again. We have made decisions in the organisation. I've got my mask with me. We've stood down large face-to-face meetings, so we've gone virtual again, and we're wearing masks in both clinical and non-clinical areas within the hospital. The issues that we're currently facing across the whole of Yorkshire and Humber actually are compounded by the heat wave of the first 2 days of this week, which we would expect to continue for the remainder of this week. And certainly the ambulance service are indicating that demand levels are significantly 150% was the figure that I was quoted, higher than you would expect for this particular time of year. So yeah, we are under intense pressure, and COVID doesn't help. But it's with us, and it's probably with us to stay. I think that's the conclusion that we have to draw. So I think it's right that we call our group now living with COVID, and I think it's important to refer to it in that way. And we're going to have to be making some, I think, probably more permanent adjustments really in terms of how we manage our business in the coming months and years.
Yeah, thanks, Simon. So, as you know, we also monitor deaths due to COVID. We are still seeing a small number of deaths, although overall, as you can see from the lower part of the slide, York has seen lower COVID deaths than other areas, which is very welcome. And the majority of those deaths have occurred in hospital. So they're really the people who have been very sick and have needed to be admitted and have specialist care. This is a very busy slide, and I'm not going to go through the detail of it. We know that the vaccination is the best protection from serious illness due to COVID. Being vaccinated won't necessarily stop you from getting COVID, as I know personally, having had COVID a few weeks ago and being fully vaccinated. But being vaccinated will reduce the risk of you developing serious illness and needing hospital treatment. We have done reasonably well with our uptake of vaccination in York, but we still have a really significant number of people in our communities who are either not vaccinated at all or just partially vaccinated. And so, it's still really important. The government have just announced the criteria for COVID vaccination for this autumn. So all adults over 50 will be invited for COVID vaccination, and indeed for flu as well, seasonal flu. In addition to the clinical priority groups, so pregnant women, people aged 5 to 49 in a clinical risk group, people aged 5 to 49 who may be living in a household with someone who has a suppressed immune system, carers, and obviously staff and residents in care homes and frontline health and social care staff. So I would urge people who are eligible for a COVID vaccine, as you start to get invitations from the NHS, then obviously going and getting that vaccination when you're invited continues to be really important. And then just a final point, really, that the guidance hasn't changed. So the government published its strategy, Living with COVID. Quite a lot of the secondary legislation around COVID and the regulations around COVID has gone. There are a few legal requirements now, but the guidance hasn't changed. And this is some of the information that we need to continue to get across to the public. Because we're not doing testing now, you can't rely on whether you've had a negative or positive test with COVID. So you need to be aware of the symptoms of COVID. And if you think you may have symptoms of COVID, stay at home. Don't go out risking spreading it to others. Stay at home. Get vaccinated if you're eligible, as we've already discussed. Wearing a face mask continues to be really important. I still wear a face mask in certain settings. In fact, I went to one of our local supermarkets on Sunday. There was me and one other person wearing a face mask. And this is despite rates of COVID going up, and we're knowing that, you know, the most recent variants are more infectious. So wearing a face mask is really important. And as Simon says, healthcare settings indeed have already started asking people to wear face masks. Ventilation is still really important. Meet outside if you can. If the weather's awful and you need to meet indoors, then obviously ventilation is important, having windows open, etc. And then hand washing, catching coughs and sneezes in tissues, disposing of them safely. Those basic infection prevention rules, very simple rules, continue to be really, really important. So it's just reminding people of that, really. And that's it, Chair.
Very grateful for that, Sharon. I think the most important message is that COVID hasn't gone away and it's not very likely to go away. We have got time for a couple of questions, if there are any. Alison.
I've got a quick question about the booster. So there's quite a few people who haven't had it. Do you have to have it within a certain time to be effective from your second vaccine? If you wait 6 months, is it going to lose its impact?
Do you know the answer? Is it still an evergreen offer as it used to be, Steph?
Yeah, so we've stood down many of our sites, but local pharmacies and Askham Bar in the city are still offering booster vaccines. And indeed, the national team is still inviting people for their boosters. So supply is a little bit of an issue at the moment as we gear up for the autumn campaign, but actually going to a site and getting a vaccine is still relatively straightforward. What we're struggling with at the moment is housebound vaccinations and just moving vaccines around the city from different places, but the evergreen offer is still open to people. Yeah.
Yeah.
Can I just come back? So it's still as effective if you have it 6 months after the second vaccine.
Yeah.
It doesn't.
Yeah.
Doesn't the vaccine lose its effectiveness?
There is a small waning of efficacy, but nothing material.
And it still provides that protection. So I think the key message is people don't need to worry about that. You know, maybe they were invited in March and perhaps they didn't turn up for their vaccine. It's still important to go. And even though the protection from vaccination does wane over time, we know that there is a lot of evidence now that shows that it still helps to protect against serious illness and helps to protect against hospital admissions. So it's still important for people to have their booster.
One quick question for me, Steph. Are we still making arrangements for people that are blind? I know we had been, so that they don't just get a letter and can't read the letter.
I don't know the answer to that specific question, actually. I will find out. It's not something that's been raised with me before. In other contexts, yes. Now this will depend on where you get your primary invitation. So if it comes from the national team, you would normally get text, then a hard copy letter, which not helpful in that scenario. But actually, if then there is a rollout through your GP practice, there will be reasonable adjustments on your notes, and we'll expect the autumn booster campaign to ramp up September, I'm going to say, and we dearly hope that the supply for both flu and COVID vaccinations can be aligned so that we can maximise delivering flu vaccines and COVID at the same time. So one in each arm. It's very it's fine. It's effective.
Well, thank you, Steph. And if you can just take that back, and if we know that you're looking at it, I think then we'll be content with the matter. Oh, sorry, Jamila.
Just a very quick one. I feel as if we're firing questions at staff. Just a quick one, because I, similar to Simon, we've a lot of pressure on staff being off with COVID at the moment. We've had the highest number off since actually COVID started, which is quite surprising. But when the vaccines, the next rollout comes out, will care staff be prioritised, or is it everybody just book in and get yourself vaccinated?
No, we'll be prioritising in the usual order, but are you thinking of social care staff?
Yeah, I'm thinking
we've always looked to prioritise them along with health staff, and indeed looking at any way that we can be responsive to release them from work to come and then take their vaccine. So Askham Bar often run late night sessions for people working on that afternoon shift. So yeah, we can definitely work with you and learn any lessons that we've had previously. Low take up in the early days, when we did a lot of the lessons learned was about some of the misnomers around the side effects of the vaccine, and we're hoping that we'll always do sort of another update campaign about the effectiveness of the vaccines. But yeah, we can do that work, and we often do all the social care staff at the same time as we go into homes as well. But I know previously we needed to make sure that we got the domiciliary care providers really early doors on that, and given the impact of the domiciliary care providers on the wider system and how we get the system flow right, then we could probably look at how we do that a bit more efficiently this year.
Okay. Just quickly to reassure Jamila, public health is leading on this for the council. So we're already developing our plan, which will be coming through to corporate management team shortly, in a couple of weeks, and working very closely with Nimbus and with community pharmacies. We're hoping that the mass vaccination centre will be available for staff, because that worked really, really well last year for flu and for COVID. So we're hoping that will be available again.
Last comment goes to Simon.
Sorry, yes, very, very brief. Just on messaging and campaigns, just to stress the importance of the flu vaccination this year and what we're seeing with the Southern Hemisphere. We've not seen any flu for 2 years, really, to speak of. We don't expect that to be the case this year. So it isn't really just a COVID campaign. It is a COVID and flu campaign that we need to push quite strongly this late summer and autumn.
It just goes to prove that washing your hands and not sneezing on people and keeping a distance actually works for any infection, just about. Right, and with that, we'll pass on to Jamila and the Better Care Fund, which is agenda item 4 on page 19. Thank you.
Thank you, Chair. So the BCF paper comes as part of a series of updates that we do quarterly for the Health and Wellbeing Board, and there's some specific changes that I just wanted to highlight to colleagues in this report. I think one of the main asks is to do the year-end sign-off for 2021 and 22. This has come a bit late as we were waiting for the final draft from our NHSEI colleague. So as we're all aware, we have got another year of the BCF, and it provides a really good lever for partners to be able to bring some of our services together, but also align some of the monies, which are really quite important around the finances to deliver our programs of support. Late last year and earlier this year, we brought in them consulting to do a review on how our services were being delivered and what can we do better around particularly around our intermediate care services, because we were failing on 2 of our targets then. It was the targets then which have changed now were delayed transfers of care and emissions. And we were failing on those 2 targets, as well as some of our reablement targets previously last year. So we brought in Ben to do a review of what we can change. That is now underway. The review is completed and work is underway with both health, social care and community colleagues around how do we do things differently. I think what they actually found, and I think correlates with some of the targets that haven't been met, is we support people very earlier on in their journey quite well. So the early intervention and prevention bit, and then the crisis bit around nursing and residential. It's the middle bit, as we've seen in the hospital today, where people need some additional support, some additional care, either by health or social care, and that element is quite weak. We have 5, 6 different services, different eligibility criteria. There's some services where you have to be admitted into hospital before you can access those services. So we usually ask, is the patient in hospital or out of hospital? Oh, the patient's out of hospital. Oh, we can't give you that service, which is all wrong, because we should stop them from going into hospital before we provide that service. So that work is underway. It's had its 3rd meeting now, and we are looking for the work to be phased in. We're quite conscious that we're already struggling for discharges and avoiding people from going into hospital. So that's going to be over phases. In October, we're looking at changing our rehab services, so our in-house services, and then towards January and April, and moving towards a single approach. And this is where Simon really talked about that collaborative approach, the York Place Board, and how the ICS can help us deliver that single pathway, and where the Better Care Fund sits in that in the future is probably up for the discussion in the next Health and Wellbeing Board. I'm not going to start that discussion today. So I just wanted to highlight some of the key changes in the reporting and some of the performance data that we've got. So some of the reports of the performance metrics have changed. So we've got now avoidable admissions. It's changed slightly from what it was around admission avoidance. And this is around ambulatory care conditions. And when they talk about ambulatory care conditions, they're talking about individuals who have come into hospital who may not have needed to come into A&E, and then patients that were admitted into hospital who shouldn't have been admitted if there was something else out there. The hospital avoids admitting people all the time if they don't have an acute illness. However, there are, as we can see from our performance, people that are admitted who could have been elsewhere but didn't have anywhere else to go. The second metric is the length of stay. The length of stay a patient stays in hospital unnecessarily. I think some people call it lots of different things, but we're doing some work on the length of stay at the moment in hospital to say, well, if a person is admitted into hospital, if they're an older person with dementia, and I've mentioned it before, can stay up to 10 to 12 days longer in hospital than somebody who's come without dementia with the same condition. And we've got the dementia strategy coming. But I think a target support will help flow within the hospital and make sure that we've got the right patients there at the right time. People staying at home after discharge from hospital with a reablement service. This target dipped last year, but it has improved in 2021 when more people actually did stay at home post 91 days with a reablement service. But I do have to say that when we talk about reablement service here, we do have a flow issue where people go out with reablement and they are still maybe on reablement 12 weeks after leaving hospital. So we might not have the right care in the right place, but people are certainly staying home for longer, which is a good thing. And then admissions of old people into a residential care setting, we have seen an increase in the number of people going from hospital into residential and nursing care. We've had changes in the D2A process where a lot of people went into step down, but equally we saw some of the acuity of patients rising in hospital. We're hoping that this will go down as we're moving through and building our admission avoidance services. It should go down, but we need to keep an eye on that because the last two put a lot of pressure, maybe not so on. When I talk about, I like to talk about the system, but I just really do want to mention that it's put a lot of pressure on social care budgets. So if we think to date, we've spent nearly £500,000 extra on residential and nursing patient placements, and another 700,000 on supporting people at home. And supporting people at home is the right way, but we're supporting people at home with wraparound care, and it's about how do we get that length of stay down, because sometimes that can increase dependency of people being discharged. And then we need to look at reviewing the scheme. So we review the schemes that we have, which is in the appendix of the report every year, but we need some more of a fundamental review with the changes in some of the performance targets and how we're not reaching those targets today. Just to bring you up where it says avoidable admissions, people might think, oh, well, 3% over target doesn't sound a lot. But in terms of patients' numbers, it is quite considerable. And we don't need to look at, I can get you the number of patients which is in the return, but it's not a small amount being admitted into hospital unnecessarily. So the strategic direction, so we have had recent emails. It was this morning, so I couldn't add it into the report as much as I want to do. So the BCF are doing a demand analysis across national demand analysis. We are looking at the BCF, obviously it's in place for 22-23, and then looking at it run over 23-24, but those decisions are still needing to be had, and how then that fits in to the wider ICS system. At this moment, this is one of the main levers we've got around poor budgets and joining up budgets, and we need to look at how well we can use the Better Care Fund further to help us. The finances are there. The BCF has a total budget of just over 20 million, and that runs with a number of schemes. So when we say poor budgets, a lot of that is aligned because a lot of that is in existing contracts, but I don't want people to think just because they're in existing contracts, there's no opportunity for redesign. There is, as you know, we're working on that. Then it's not about procuring services or going out to the market or decommissioning things. It's about saying the services that we've got, if they're not running in a way that we need them to support the population, how can we redesign that? And that's a new way or a different way of thinking. I don't think it's new, but it's a different way of doing things, and particularly for council services where we are talking a lot more redesign than procurement now than we did before. So just moving on, I think we have got the risk there. I did put the risk of the memorandum of understanding, but colleagues, and I have to thank our CCG, because I have to say CCG because it was CCG on the 31st of March. Colleagues pulled out all the stops to get the memorandum of understanding signed. So thank you, Steph, and your team to do that. So that's no longer a risk. That's signed for subsequent years of 21-22 and 22-23. So Chair, it just comes now to the recommendations and the attached return, which you probably need agreement on.
Thank you, Jamila. You'll see the recommendations on page 23. where we have to agree the attached and then delegate the authority to me with the corporate director to sign it off. I can take one or two questions to Jamila if anybody has any particular questions. Sharon.
I suppose it isn't a question for you, Jamila, but a question for us as a board, particularly for those of us who are members of the York Health and Care Alliance, and a challenge to us all, really. You know, those two key performance indicators that we're not meeting, avoidable admissions and length of stay, between them, they represent a lot of resource, a lot of cost pressures that we're experiencing across the York Health and Care system at the moment. So I know we've got the York Place paper next, but I suppose if we could keep in mind when we're reading that paper, and challenge ourselves really as to whether the Alliance is actually focused on the right things. And, you know, it has a range of priorities, but would it be better to have fewer priorities, such as these two, and say, well, how as a system are we going to address this then? Looking at the whole of the pathway from prevention all the way through to rehabilitation, with a focus on achieving those two outcomes. It's just a challenge for us, really. I'd like us to bear in mind when we're looking at the next paper.
Simon?
Just to support Sharon's challenge, I think that I think the point is, yes, we should have fewer priorities. It isn't just the risk of cost in the system, it's the clinical risk, the risk that there's a serious risk to the public, really, in terms of what the consequence of not achieving those two targets. So it is important as a system that we collectively focus on it. So just to echo Sharon's comments.
Yeah. Thank you, Jamila. You'll absorb those comments and take them back to the right place, I hope.
I will, and I think it's really important because I'm starting assignment and pulling in and out of hospital care because I don't want people to get focused on discharges or focused on mission avoidance. It's that pathway of in and then out of hospital care that we need to focus on. But yes, I will keep it in mind.
And looking at it as a whole system issue, you know, the solutions aren't just in social care, they're not just in NHS. So I would hope that we can have a conversation at the Alliance, which is about how York Health system can address those two issues. And personally, I think it would be helpful to have two key priorities and say, well, how are we going to achieve those outcomes, set ourselves a target, and then work back and say, well, what do we all need to do then, the whole system across York, to help us to achieve those two outcomes? Because that's the only way that we're going to release resources to invest in the other things that we want to do, because all of the money is being sucked up in acute care at the moment, and we need to be able to kind of realign that system so we can put more into prevention and early intervention. We're not going to be able to do that and unless we kind of really focus on it and commit to it, and we kind of reduce. We only have so many resources, and I think we try to do everything and then we just spread ourselves too thinly, don't we?
I think that message has come over loud and clear. Thank you very much indeed. Right, I want to move on to the next item, which is agenda item 5, which is the York Place update, and it's Jamila again.
So again, this is the regular updates to the Health and Wellbeing Board, because as you know, it's everything's all very new and coming together for the York Place Place Board and the ICS. So the York Place Health and Care Partnership Board had its second meeting just a couple of weeks ago, and we presented a paper exactly what Sharon is sort of saying around, you know, setting our stall out about the Alliance, the work that the Alliance has done over the last 12 months. We didn't really want to lose all that because there was a lot of good work that the Alliance did, but equally how we then going to take it forward as the board developed. As people know, we've got a chair of the board now. Ian Floyd. We're still waiting for the appointment of an NHS director, but this is not stopping board members from delivering what we need to do for our place. So just going back to the paper, and during 2021, York Partners had a health and care alliance, and this is what Sharon was alluding to, was chaired by Councillor Asperdon, and they had some key priorities in there around learning disabilities, complex care and diabetes, some really good whole system working happened there around how do we deliver for those individuals. And alongside that, they had the key priority of reducing inequalities. From the data, I'm not going to go through the data again because I think Peter highlighted it really quite well in the health and wellbeing section that he did around where are our key health indicators and what we shouldn't lose sight of, and that's the last bullet point, is that good health hides uneven health, and I think that's what we've got in York, where we've got pockets of people who are living longer, healthier lives, but equally we have pockets that are not, and we're seeing that a lot in the pressures both within social care, primary care, and our acute health services. So I'm not going to go all through the paper, just the national and local context so people understand where this has all come from. So the York system, the ICS, way back in December, there was some planning guidance that was set, quite clear planning guidance that sort of supported a more of a health and social care approach with our health services. I think it's one of the better planning guidance or operational guidance I saw in a while in December, where it looked around investing in the workforce and strengthening a compassion and inclusive culture. But equally, it were all those bullet points from 1 to 10 quite clear about the system working together, and then we also finished on establishing ICBs. This is where some people call it the Integrated Care Board and an Integrated Care System. So lots of care systems on board there, and the Integrated Care Board is now in place, and Simon, I think, is a member of that board. I hope you are. And then obviously we had some more changes in April. In April this year, we had the changes in the Act, and now we have a Health and Care Act. For those who don't know, we had an Act that was in 2012, which was all about setting up of the CCGs. So the CCGs came into being following that Act, and since the development of the ICSE, so a wider system, changes to legislation has brought about the closure almost of CCGs and the stepping up of the ICSs, and then that has led to place delivery system. So York Place Board is one of those, and that Act and allows the system to commission hospital and health services, primary care, transfer of schemes. So some of the functions of primary care will fall into the ICS as well. Looking at commissioning arrangements, and I talk about commissioning in the widest sense because, you know, with the Act changing slightly around how we commission or how we redesign, but the Act still talks about it in the sense of commissioning services. And then the expansion of the financial duties. So the integrated care boards will have duties around setting the finances, and as the York Place Board grows, it'll be how that integrates with the board as a committee or as a subcommittee. So just moving through the paper, I wanted to come to the point of where do we go? Where do we go now? We know that we have an establishment of the ICBs. We've been a York Place Board in the paper I brought previously about us establishing a way forward. We equally have assured ourselves on what the Alliance did previously and build on that. And it comes back to the next place board is to set those priorities on what those priorities would be. So the paper I took to the place board recently is about how do we then move forward with what I call work streams or subgroups of the place board. And these aren't groups that aren't already in place. So there's still groups who are delivering some of the things that we need the place board to have oversight of. And the key elements we discussed was quality and safety subgroup, sustainable and integrated workforce, because that's something that we talk a lot about as a system. How can we have a system integrated workforce? Performance management and financial allocation at a place, and how does that now change and differ, and what that substream will do. A strong governance framework that leads to the Health and Wellbeing Board, the primary care network, because we know that that's something that's essential going forward at a place. And then the early intervention and prevention, and this is what I call it the in and out of hospital care, because I'm trying to avoid those key uses, words around admission avoidance and discharges. So the next step we discussed were to look at what groups we already have in the system that are working, that can form part of the York Place Board, how we can develop those strong relationships in the system and not lose what we've done while we're going through these changes. How the BCF works through what we've actually done as we've gone through. We haven't lost any of the BCF, as I've just talked about, or any of the integrated working that we've got, you know, what we call sections 256s and section 75. Those are still carrying on. They've just been aligned with the ICS. So we haven't actually, the move from the CCG to the ICS, just wanted to reassure people that we haven't lost any of that integrated working, or where we've got integrated financial systems, they are still in place. We're still moving towards the place board to establish itself very early on. We've got an operational plan, and then the Health and Wellbeing Board strategy. I think it's really important to ensure that we align that with the ICS 5-year strategy as well. I know the term is different, but then the delivery of services on a place, which that board will have oversight on, needs to be really quite aligned, because we can't have two strategies talking about slightly separate things. And then we discussed the membership. So the membership remains as it is, as the place board develops. What are the one additional core membership providers again is going to be Healthwatch, because we felt that we didn't have the representation of people's voice or patients' voices in the place board, and we need to have those. So Healthwatch will be at our next meeting. There are no legal implications at this moment in time whilst we wait for the ICB, particularly for the councillors. This is primarily a substantial change in health, but a substantial opportunity for the council as well to work much more closely with our council colleagues. So just coming to, I know I've whisked through that, there's a lot of detail in that paper, but I just wanted to assure people that the work is ongoing. We have moved at a pace on some things, but slower on others. But we're now at a point of, in the next meeting, establishing what our priorities, or having a discussion about what our priorities should be. I agree with Sharon. We shouldn't have lots of priorities, otherwise you don't actually then deliver anything, because there's too much to do. But going to the recommendations there to board members to agree the context, although there's a lot in it. There's a lot we've done as partners to date. To work on the previous York Alliance and the work that they've done, and build on that for the York Place Health and Care Partnership Board. I do have to say that name may change. It's a name that's had, we've had lots of different versions of that. So I've stuck to that one at the moment. And then just to note that a further report will be presented to the Health and Wellbeing Board, highlighting specific issues. Won't be quite as in-depth as this one. I think this one wanted to set the scene of moving away from the Alliance to the Place Board.
Yes, and I think we'd all recognise the work of the Alliance. I'd just say I'd like to say the chair of the Health and Wellbeing Board is still waiting for an invitation to attend. And I think it came out in the recommendations or legislation, but I haven't been invited yet. And I can't wait to attend. So I can only hope that that will happen fairly soon. Not for the want of asking. Time for a couple of questions, if anybody has them.
Yes, I don't pretend to have got my head around any of this at all yet. And I'm not really putting an awful lot of effort into it. It's passing me by. But I note among your risks to continue to work with elected members, ensuring they play a key role in the development of place. What elected members, which elected members? I mean, I'm not quite clear as to which groups you are looking at, or is it a broad spectrum across the whole range? I have a horrible feeling it isn't, but I wait to be persuaded.
So I put that as a risk there because it's the whole range. So when I mentioned it's a opportunity for the council, I think it's for all elected members to be a part of this, to understand the relationship between the ICS and the local authority, because I do think this is in my lifetime of working, and I've only been, I'm only young, so I haven't been here long, but in my 26 years, I think this is the first opportunity I've seen where you can get that real integration. So it is for all council members, Councillor Luca. So hopefully I can meet with you so you can understand it and get a lot more engaged in it.
I'm not too worried. How then? I mean, what I'm assuming is there aren't formal places on the particular group for elected members. So is it going to be through informal consultations? Is that how you're going to do it?
So elected members do have a place on the ICB, so the Integrated Care Board. Elected members have a place. No, not member, but the leader of our council certainly has a place on the board. So will the chair of the place, and also the NHS director when they're in. I think what we have to do, which we're still establishing, is those engagements and communication sessions, and that's one of the core subgroups that we've got here to make sure that we have got the communication and engagement right. But we're in the place at the moment where we're still developing as a board and still developing as an ICS, because it only came in sort of April time and it takes a few months to develop. So hopefully by this time next year, it will all be much more clearer.
I think we can ask the questions again, can't we, Janet?
I shall keep asking.
Yes,
Thank
I
you.
think that's absolutely right, as will I. Right, that's lovely. Thank you, Jamila. Now we go on to Sian. And I have to say, these papers took a lot of reading, but that first one, your first report, was the most interesting bit of all, I think. Not wishing to denigrate anything else, but it was absolutely fascinating, and I'm really pleased you did it. Would you like to? Do you want to introduce the report first and then the annual report afterwards? Thank you.
Yes, thank you, Chair, and thanks for your interest. I'm very, very delighted. We like to produce things that people want to read and find interesting, so that's lovely. This is actually the first piece of work we've done jointly with Healthwatch North Yorkshire, and I think it was really interesting that you started the meeting by thanking the technical team here for enabling you to properly participate in a meeting through the provision of a hearing loop. I think it's very easy to forget that many of us take for granted our ability to join in conversations and have information in a format that works for us. I know that many of you will already be aware that we at Healthwatch York follow the social model of disability, trying to consider the barriers that we put in the way of disabled people that prevent their full inclusion. accessible information isn't just about disabled people, but many of the people that we spoke to as a sort of part of building this report were disabled people, and their needs were not being met in terms of access to information, in terms of being able to fully participate in having choice and control over their own lives, over their own health and care decisions. I should say there were examples of good practice as well. This isn't a wholly disturbing picture, and it was nice to hear that some people are getting exactly what they need to, but I think there is still an emphasis on disabled people themselves fighting to get their rights met, rather than an acceptance that we collectively should be enabling them to participate. I think there are within the report, there are 9 recommendations. I hope that every organisation has looked at them and had a think about that. I know it has already been accepted by the hospital, and we've had some good discussions about the work that you've already been trying to do and the work you continue to do. I think one of the issues that probably isn't directly raised in the report, but I think we as a system do need to think about, and particularly with the York Health and Care, I'll get the name wrong, Partnership Board now rather than Alliance, it's very confusing. There is an opportunity for us to think about the fact that our system does not currently have a simple way for deaf people to get an interpreter wherever it is they are trying to access the system. That has been an issue since I first started in Healthwatch and many years before that. So I think the great thing about the changes to health and care are we have new opportunities to think more systematically about removing those barriers and enabling people. And I hope we embrace those. I'm assuming you've all read the report. I hope you all found it as interesting as Carol did. But if you have any questions, please throw them. And if I know the answer, I will give it. And if I don't, I will go away and find out.
Thank you, Sian. I think the most important thing is that I don't spend my life feeling disabled, but I am if I can't hear. And that's why the loop in here is so important to me. Other than that, I'm absolutely fine. Thank you. Any questions to Sian about that most interesting report? Right. Jamila and then Sharon.
And I think it's one of these things where we always think or assume that we get the communication right, or we explain our services right. That's without jargon. But I think in your report, it's quite clear about the accessibility of information, because information is always power. Whoever has that information has much more of the power, and you don't want to, if I use that term, disable people by them not having all that information. So that's really quite key, and it's something that I'm going to have to take back to say, well, do people have access to the right information when having choices about their care options, whether it's children and young people or adults having that particular choices around that? And we probably need to have a re-look at that, because when I was looking at our local offer in terms of this report, there were a number of things I'm saying, well, I'm not quite sure if that's the council language or language that we're asking our population to understand and digest. So it's been really helpful just to have that in there.
Good. I'm really glad. We like to produce, like I say, interesting, useful things that make us think, can we do this better? So great. Thank you.
Sharon.
Fabulous report. Really enjoyed well, I can't say I enjoyed reading it, because it's kind of very thought-provoking and really challenging. It's a good report, but it kind of made me question lots. So I'm sorry I'm being controversial this evening, Chair. But it's how we can make sure that this isn't just a nice report that has come here and we've read and all like it, and then we go away and never look at it again. So, looking at the recommendations, which, no one could argue with, have significant implications for all of our organisations, and the training we do with staff, etc., etc. So, I suppose I would like us to agree some actions, Chair, as a board, so that, you know, we can make sure that something happens as a result of this?
Yes, I can absolutely see that. Simon, and then I'll make a suggestion. Yeah.
Yeah, sorry, because I do need to go at 6. Sorry, Chair, but I did enjoy reading it. Actually, I absolutely get that there's some disturbing stuff in here, but it is a fantastic report, and certainly our guys back at the hospital have really embraced this, and we do want to tangibly set ourselves some real objectives here through our fairness forum about how we address some of these issues. But it is what's really striking is how different we all are in our different professional, even within the NHS, in terms of how general practice communicates, how different hospitals communicate, even different hospitals within the same organisation communicate. So we do have to think about that. It's back to that Alliance Health and Care Partnership conversation, and whether we set some clear objectives that this Health and Wellbeing Board holds the feet to the fire of the partnership, so that collectively we're seen to be responding as one, as a city to this. Because I think it's a really, really, really good piece of work that you can't help but think, actually, we have to do something about this.
Steph?
A couple of points. One practical about how we put this on the agenda at our protected learning time, because it's not surprising that the theme around accessibility to GPs comes through strongly. We do almost 1 million appointments a month. Okay, just let that settle in. So, and of course, over the last 2 years with the pandemic, we moved rapidly to telephone triage. And I wish I could say we've had an opportunity to take a breath, to reflect on whether that's been good, bad or indifferent. And there's a multitude of things where it's saved everybody's bacon, but there's been some significant issues, not least sort of the whole digital exclusion agenda. But there was another point, so definitely about PLT, that is a practical thing, and I will go away and make sure it's on the agenda in the months to come. But it's a real practical thing in that we've lost one of our senior links in, I'll name Victoria Binks, but the post remains unfilled. And it's one of the dilemmas when the NHS or any organisation goes through a slow and protracted reorganisation, in that we chose not to recruit into that post because we didn't know what the organisation would look like. And then over months and months and months, we just simply haven't recruited to that post. And quite frankly, we've got something close to a vacancy freeze. Now, I was going to raise it at the Alliance, and I've asked our head of comms to look at it, but that was our senior engagement post, who would have been a real link into driving this forward. So I think when we start thinking about at the York Health and Care Partnership Alliance bit, what do we want to do for York Place? We rapidly need to be moving into highlighting our voice about what we want to do at York Place. So it's not about conformity to an ICS model. And if we drift into that, we will miss the nuances of York and everything that we talked about in the strategy, in those big things, which is good health doesn't mean even health. You know, it's very easy to people to drift into the shorthand of York being a healthy city, and we know that is something that we have to interact with our colleagues for them to understand a little better that shorthand does us a great disservice. So definitely PLT, but I want my colleagues to just be thinking about how do we actually start raising the profile of some of those vacant posts that the CCG and now Place sit in their portfolio, and we need to be challenging how we get resources at Place, because that's the mantra, that it's 80% of activity at Place, 20% activity at an ICS level, and we just need to challenge that.
I'm going to ask Sian if it's possible to bring back a report to another meeting about what people have done. Now, obviously, Simon has done something we don't know any detail because he's A, we haven't got time, and B, he hasn't got time. But when we look at the recommendations, asking members to respond, I think it would be good, Sian, if you can tell us what sort of responses are coming back, because some of the issues that come up here are so terribly basic. And you think, you know, why didn't people see that before? But they very clearly didn't just do so. Do you think that's possible?
I am very happy to, as long as everyone else is happy to tell me what they've done, which I'm sure between us we can sort out. And I think it's really important to note that a lot of the principles that underpin this, we first, you know, collectively became aware of them through the Disability Discrimination Act in 1995. We then had the Equalities Act. We now have the Accessible Information Standards. So most of this stuff isn't new, and it's absolutely right. We talk about action and how we collectively tackle some of this. And I must say, Healthwatch North Yorkshire led this report, so I might be getting some tips on them because you seem very engaged and interested.
It's just a proposal for the board, really, that rather than asking Healthwatch to kind of write to each chief executive asking for a response, we could take this to the York Health and Care Partnership, formerly the York Health and Care Alliance, with a cover report, I think, that I'm happy to coordinate and pull together. The cover report with some specific things that we actually want the members of the partnership to discuss and agree on, so that we can be confident that, you know, that not everybody is represented. I don't know that the police are on the Health and Care Partnership, so we'll have to think about how we engage with people. But it just seems to me that it's our responsibility to do that, not Healthwatch, and then give you a plan that has been agreed as to how we're going to take it
I
forward.
accept what you say, Sharon, but I would like it to come back to the Health and Wellbeing Board, because the report came to the Health and Wellbeing Board. So in whatever format people decide is best, I'd still like it to come back to the board.
Yeah.
Fine.
Yes, yeah,
Right,
because
now,
the board needs to be assured something
they
is
certainly
happening.
would, having had the issues raised. Now, your annual report.
Thank you, Chair. And again, I'm assuming everybody's read it, so I don't want to sort of go over it in great detail. I am aware we are slightly behind time on the agenda as well. But I hope, again, you enjoyed reading this. It is part of our statutory responsibilities that we publish an annual report and bring it here for you to know what we've been up to and thinking about what we'll be up to next. I think what we have tried to show throughout this report is our belief in co-production as the right model for developing, delivering, designing services, the importance of partnership working, that actually collectively we can achieve much more if we do it together. And our role as Healthwatch to speak up for people doesn't mean we have a cupboard somewhere with a group of people sat in it waiting to tell us what they think, but actually collectively we all have a huge number of people that we reach every single day, and how do we collectively bring that voice? I am particularly happy, I know we're talking about the dementia strategy shortly, but I think the way that partners really welcomed our input and involvement in that work, the way that this board has welcomed the reports we've done about dentistry, and that those have been used at national level in Westminster Hall debates and elsewhere. And I think that is basically what we try to do in this report, flag up not just the work we have done, but the difference that can make to people when we do this well together. So at that point, I will stop. And if anyone has any questions, I'm very happy to answer them.
Yeah, thank you, Sharon. We haven't extinguished the Chief Constable. Any questions from anyone? No? Sharon?
You know, I'll always have something to say. It isn't a question at all, Sean. It's just, this is incredible. The fact that you're such a small team and you have managed to do all of this work. I don't know how you do it, but I really enjoyed reading this, and it's just a snapshot, really, isn't it, of all of the work you and the team do. It's absolutely incredible. Please, I think it would be useful if we could record a formal thanks in the minutes, but please pass that to the team, because you do an incredible job.
Yeah, I think that's exactly right.
I don't know why I've got so emotional. I do apologise. I'm blaming the heat. I'm blaming the heat, but my team are fantastic and none of this would happen without them. So thank you for recognising that.
That's great.
Can I just say, I mean, just looking again at this report, it is an example of an accessible report. I mean, you actually do what you preach, and I wish all annual reports were quite so legible. But it's very good.
Pictures and
the
diagrams
pictures
do
are
help.
lovely, especially the teddy bear.
Yes.
Every annual report should have a teddy bear.
Right. That's it. Sorry, thank you to Sean and the team for all their hard work, and we'll record our formal thanks to them.
Do we want to take teams on to next? Do we want to take teams on to next?
No, we're okay. So dementia strategy. Tamela, it's you. This is an absolutely crucial thing, which very much ties up with what Tim is going to tell us about next.
Just for colleagues, I brought a very draft version of the dementia strategy a few weeks ago, and my colleague Abby Hans and Sheila from CCC have worked quite hard on further developing the strategy. So it's there in draft at the moment. So we've had some more group discussions. Sean, thank you very much. Oh, we seem to be thanking Sean today. Thank you very much, Sean, for all your support on this and ensuring that we captured additional voices of people and users of the service. And it went to the Dementia Collaborative last week. Abby took it there. So I just wanted to run people through the strategy. So we've put in the national context a bit more clearer. I think colleagues were sort of saying, can we look at what numbers and how that dementia is set to rise as we go through the population. I did want to bring people to the slide that we've added in around the data that's very pertinent to York around the number of people living with the dementia and the estimated number of people living with dementia in York. So 2 out of 3 people with dementia in York are living in the community, which is really quite good. So we've shown that we've already got those establishments supporting people in the community, and one third of those live in residential or nursing homes. However, our diagnosis rates are quite low, and then this affects really the amount of early support that we can offer people as they're experiencing dementia, and their carers to support them to stay at home longer, coming back to living well for longer, and how do we get that early diagnosis. We also, I also need to say by 2030, and although it doesn't sound like a high number, it is quite a significant number. 3,860 people by 2030 will have dementia, and dementia not just affects the individual, but the carers, the family, the wider community. So when we talk about the number there, we need to look at much wider number. But out of that, 2,438 will be living with severe dementia, and that's the rise in the population that we need to look at supporting now, and that's on current projected levels. We may have, once we start looking at diagnosing people earlier, number set to rise. So just wanted to raise that with people so we understand the context of this. And coming to this carers, what we do know that 60% of our carers feel stress and anxiety whilst caring for a person with dementia. And it's how we then support people with dementia in York, but equally, when we look at money savings, the savings, and we shouldn't always look at it in savings term, but carers actually save the system around about £100 million a year, and that just shows you the significant care informal. I mean, I tend to use that word very loosely when we say informal carers, but carers of people living with dementia, and the huge savings they have. It's about this strategy, making sure that we invest in services to support our carers to carry on that role, because many who we've spoken to said they absolutely would want to carry on that role. But how do they then support themselves and their own well-being as they support their loved ones or family members? We are a dementia-friendly city, and we've put that in there to say, you know, there's a dementia pathway in York, and we are a dementia-friendly city, improving all the time the support that we give to people with dementia. And I think the last time we came, people wanted to understand, okay, what does that mean? How do we link that into preventing well? So in the strategy, you can see we've gone on specific areas of preventing well, supporting well, living well, and then dying well. We had a bit of a discussion last time around dying well, and we think it's really, really important to support families and people through that, the whole life journey. And we had a discussion at our scrutiny around dying well, and when people did raise, one member did raise that they supported a loved one when it was the end of life, and what that impact of having a good death and the individual being able to say where that should happen, how their death should be, and how they individuals should be cared for. And this is where we come back to, and they all seem to be connected, don't they, today, around the York Alliance, the report that you did, and the BCF, but metrics around length of stay and how we support people to be out of hospital as soon as we can to support them in their journey. So that is the strategy. I hope people found the
draft strategy.
It is.
Right. So before I ask my question about that, which is going to be what comes next, I'll just say that I was very interested when I talked to one of the dementia organisations to find out that they will support people without a diagnosis because the rates of diagnosis are low.
Yes.
But I wonder if you could tell us now, this is draft, what comes next?
So what comes next is the other attachment around the key action plan. So you can see in the key action plan, one of them is primary care interventions around increasing the number of people with a dementia diagnosis. So it's clear there, and I can't see it with my glasses. So it's clear there in the action plan around what we want to do, supporting more access to primary care, supporting access into services, offering more face-to-face appointments around the diagnosis. And this is where we want to really capture where we have services that support people without dementia. We think it's really important to actually have a diagnosis so we can offer them a full range of services. And then we've got a full action plan that we've created alongside Healthwatch and others to say, okay, this is the strategy. And that's the action plan, which we will then form part of the dementia steering group and ensure that that plan is being delivered and updated to the Health and Wellbeing Board.
Where will the completed action plan go? Does it go to the Ageing Well group? Does it go to the mental health group? Does it go to both? Where does it go when it's complete?
So this action plan, because this is a draft, we're looking at this to be so we've it's been everywhere. So it's been well socialized. So it's been to Ageing Well. It's been to lots of other boards. So we brought it here to say we think this is ultimately a more of a final version, so a final draft version of the action plan, taking comments in from the Health and Wellbeing Board comment today, and then the executive, which will go in sort of September time. So we had a very draft action plan that we brought to the Health and Wellbeing Board a few weeks ago. This is what an action plan that we have worked with a number of people, and including users of the service, to say this is what we will deliver as part of the strategy.
Any questions?
I think it's a really comprehensive plan. It's taken a long time to get to this point, but we are here now. So I just want to say thank you to Sheila Fletcher, who I think did quite a lot of work for you, Kevin and Jamila. Just one question on the delivery plan. I think some of this can be done probably as business as usual, but some of it's clearly going to need extra resource. So I think it would be useful to have perhaps another column to say this might be dependent on resource, because it's not going to happen unless there's some resource, and where is that going to come from? So I think that's just something we should bear in mind, and perhaps have some mention of, perhaps with another little column, potentially. I don't know what you think about that, but can't be forgotten.
A really good point, but I think a lot of this work is work that needs to be underway. I think resources would always come into it, and hence why we come back to the system working in this, because I think with the action plan, some of it is can be done in business use, but some of it has to be done within the redesign. So we're not looking at sort of do we need extra money, financial, and we may well do, but how much can we do in the redesign? And we didn't really want to put in a resource column there, because sometimes it turns into, why shouldn't we do something? It can turn into it's a positive on one thing, but it can also be a negative. So what we've said to people who are going to be part of the steering group is, how do we make it happen?
I'm almost certain that Zoe will want to contribute, if not now, because she's only been in the job 5 minutes. When it comes back again, I thought you might, yes. Janet next.
Yes, I just wanted to pick up again, and I know you say it was a matter of some discussion at scrutiny, dying with dignity in a place of my own choice. I had information just recently about a very, very, very old friend of mine who has just died, and who wanted to die at home, but struggled very much to get that support. It wasn't dementia, it was, I think it was cancer. But her family found it was very difficult to get that level of domiciliary support and care at home. And I mean, this is something that, again, I'm probably looking at our medical GP colleagues particularly. It is something everybody wants except me. I want to die alone in an anonymous ward. I really do. God.
It will make a note.
Yes, I certainly don't want to die at home. Like, with cats
Right,
all over the
enough.
place. Anyway,
Right.
that's irrelevant.
Right.
But I just wondered how,
Yeah.
when there's a comment from the GP
Right.
sector.
Steph is ready to respond.
So first of all, I want to just comment on dying well, which is actually about choice. So that's the key bit. So I think that we'd all agree with that, and we all have different choices. I do feel for Sheila. Most recently, in the last couple of weeks, she has been engaging primary care on some of the contractual levers around doing this, and structurally it's not as simple, but I was heartened to hear your comment that without a formal diagnosis, GPs can undo signpost people to services. So I think maybe we might be overwhelming our dementia nurse with expectations that might be too great for one individual to achieve. But my experience of some of our specialist nurses across the board, Parkinson's nurses, is that you get somebody who is wholly motivated and that sort of energy and motivation take others with them. So I'm minded by colleagues who've gone before, which is get the balance right about not striving towards only focusing on getting your diagnosis numbers up, because it might draw resources in the wrong direction. I'm not saying it's not important. So I think there is something about how we make our services accessible, so you don't have to go through a GP to access them, actually, quite frankly, and therefore do what we say we want to do, which is support and empower our carers and our citizens to access the services that they're quite capable of accessing. It's just we make navigating them really very complicated. So
I think you make a really important point, Steph. I really do. You know, if we must have a label on something to get treatment, we're doing it wrong as far as I'm concerned. I mean, that there are some things which do need labeling to get treatment, but I don't think this is one of them, because it's a gradual process and it depends where you've gone along the process and where your loved ones see you've gone along the process. It's not a simple thing. It's not like saying you've got chickenpox or something where you either have or you haven't. This is much more complex, isn't it? So I quite agree with what you're saying. Any more comments? Okay, thank you very much. Tim, you're on. Tim Madrick is going to talk us about citywide mental health transformation, and she's got some slides, I know. So, Tim, it's all yours.
Okay. That's right. Thank you. Thank you very much. Thank you, Chair. If I may, just one point, because you did refer to the mental health partnership and the dementia strategy. I think really welcome that. I've got a meeting with the chair of the Aging Well partnership just to clarify that issue, because sometimes things have come to the mental health partnership, sometimes it's come to the Aging Well partnership, and I don't think that confusion has helped. All I would say is that I agree wholeheartedly that a diagnosis isn't the be all and end all, but for several years now, York has had, when I directly inquired regionally and nationally, a low diagnosis rate that didn't seem to be able to be explained in terms of badge or not. And I would, from a personal perspective, I would agree 100% with the support for carers, absolutely. But I think there is something that blocks access to care if there isn't certain diagnosis. And I'm going to talk about diagnosis in a different way in just a moment. And of course, we shouldn't have that. Of course, people should be able to access support and care. But the message from carers when I went to the carers centre was sometimes we cannot get that support and it's blocked. That's not our aspiration. And just to reassure each other, I'm having that conversation. Just have that clarity really, and with Jamila and others, to make sure we know we're not sort of overlapping, because there's so much work to do that there doesn't need to be any overlap. So sorry. Just before I'll whip through the presentation quite quickly, because there's a couple of main points I want the Health and Wellbeing Board to be aware of. Some exceptionally positive, some really challenging. So I'll do the really positive to start with. I would echo your comments about Healthwatch. I think they punch well above their weight in terms of their resourcing. And the reason I say that is because their efforts in co-production for mental health and the work we're currently engaged in has been excellent. And I'm not saying that because Sian is here, because Sian will often challenge, in meetings about all sorts of things, but that's the truth. And the truth is, in safeguarding as well, I see exactly the same level of support. So in relation to what I'm going to say in a few minutes about fundamentally having co-production as a part of the future of mental health service, Healthwatch played a blinder, quite frankly. If that appears in the notes, it's very good. Just briefly, you'll have noted the paper itself. What I would say is that actually we're on the cusp of an opportunity in York that if we miss, we'll rue for years and years and years, in the sense that we're talking about an approach to a system across the city with all partners obviously health, but the police, the voluntary sector, in a way that we haven't seen, well, I haven't seen in the last 4 or 5 years since I retired from policing. And that's exciting. And the commitment, when you put that in the context of mental health demand at the moment, and the fact that people are, and I'm sure you appreciate this, and Chew did produce projections, and actually those projections, people said, I remember at the time people saying, oh, we think they might be a bit overstated. Well, they weren't overstated. And actually the projections for the next 5 years are quite startling. And so against this backdrop, we've got people engaged in this process of change and wanting to change, but still managing a significant demand, both across children's and adults' mental health services. The paper is self-explanatory. I'll come to the last point in the paper when I've just done the presentation very quickly. The opportunity is this. We want to develop a hub, and you bottom dollar to go on, which has, and we are in the process of doing that, which has engaged a group of people in the city who haven't been engaged with and haven't felt they've had a voice at the start of a process. They've often felt they've been consulted once a paper has been written. And that's a very different starting point, quite frankly, because it's often in official language. I've read more police papers that were difficult to understand. I've now read more health papers that are difficult to understand. But you've got a dragonfly in it. It's going to require certain things. The bit today I'm going to talk about for the last 10 minutes is about the development of a hub. The hub is not the be all and end all. The hub is a starting point for integrated systemic change in the city, involving all the partners. And that's, and I've listed some. We could go on to list a vast number, because the community and those people in the community are absolutely as critically key as a specialist in psychiatry or a specialist in eating disorders or whoever. They're all key in this. And I'll go on to talk about the CVS and the investment in the CVS in just a minute, because again, there are roles there that are so important and are, we view, as specialist roles. They're not, they're specialists in their own field. So the biggest one is culture in all organisations, culture in the City of York Council, culture in primary and secondary care. It's there across every organisation, but there is a willingness and excitement at the top of organisations to look at this. And the Community Health Transformation Fund, which is a national change programme, had at its heart service users designing service and it being person-centred. We took that on. We were fortunate enough, and you can read all the sites in a bit more detail. There's some would have some detail in there, but we went to Trieste a few years ago and saw what was possible. The list is there, but it is whole system, whole person, whole life, with a challenge every time that it's about the individual need and how we meet that need. The hub is a starting point. We were fortunate enough to get a grant to work with the Innovation Unit, which you'll see there as a national social enterprise. They're currently developing a similar system in Derby, and they've worked in some of the London boroughs. And I'll just refer to Lambeth a bit later on. So some of them are quite mature. Some of them are probably the same state we are. We engaged in this for several years before the Innovation Unit started. But we've had the co-design group with a mixed group of people, as I said, service users, members of voluntary organisations, and some specialists within that. The hub will be a fully integrated team that will deal with a cohort of individuals in the first instance. Because what we're going to challenge is, if a person presents at the hub, they may be referred, they may not be referred. Their needs may be fairly low level, their needs may be very extreme. But they will be treated as an individual and supported to get the help they need at that particular time. They may, at one level, they may be referred to a community project in Town Hall. At another level, they may get access, speedy access, to try and find the right level of specialist support they need, but they will be supported by individuals within the hub. And we will learn from that, and we're going to do it at speed, and it's going to happen this autumn. And what I would say, and it's in the final ask, is that organisations in the city have been asked, and of course TUV and others, to allow clinicians to be part of that process when the prototyping happens. And it's essential they are. You can't do this without their help, but we are going to need them to be released in the autumn for a period of time. And without that, we'd miss that opportunity. So moving on, I'm not going to, it's always, that should have been on our in-person conference yesterday and would have been about half the size of the wall, but there we are. You can, hopefully you'll be able to see the slides. The point is, it's a radical change from where we are now, and it will be difficult. Anyone involved in a change program that shifts power to the person who is seeking support, as opposed to the person deciding how they allocate it, is quite a major shift. As I say, it is possible though. And when you look at that top #1 picture, that's the promenade in Trieste. They're doing it as we speak. And I believe Derby are on the way, but there aren't many places where, as far down the line as we are. So please have a look at that a bit more at your leisure. And we've got some principles. These have been guided by people who actually try and access service for themselves or for the people they care for. Our greatest critic, but friend, challenges everything we write and says, what does that mean? Is that just health speak for something? Is that just, and she's right, of course, and we all fall into that, and I'm not, because every organisation does, but there's words in there that I think you'd all sign up to, I'm sure. I mean, you do already, I know, but it's putting it on place and seeing the practice being delivered. The hub will be a physical location in the city, but it's only the start. I believe there'll have to be maybe several hubs in the city in the fullness of time. I don't know exactly how many, but then, I'm sure there's many around the table who could talk in detail and spend their lives trying to bridge the gaps between various sectors in health. But we've got an opportunity. Again, forgive the detail on the left-hand side. I think it's interesting. The quotes on the right-hand side, the core role is supporting people with unmet mental health needs. We know the mental health demands at the moment, there are an awful lot of unmet needs. It's a bit like the conversation and Jamaila's presentation on dementia. We know that. But we also know from evidence that if you have an opportunity to find a suitable intervention based on personal need, your chances of then being referred to need secondary and psychiatric care are significantly reduced. One of the things that they saw in Lambeth after hub creation was that a lot of people didn't get referred. And much as the way GPs are seeing at the moment with their intervention in terms of the support they have, where their demand last year or the year before, I forget which figures they quoted, were, they were dealing with X hundred. Now, with the access to specialist mental health support linked to the GPs, they're referring far few for specialist care. This city is awash with brilliant community programs. Thing is, some of these people are too frightened, don't think it's for them, don't think they could get through the door on the first occasion, just need that support to do that. Again, the feeling is, and this is very much linked to what we saw overseas, the hub is a place for me, however I'm feeling. The beauty would be that some people are just having a bad day, maybe only have a bad day once in a while, just need some support. Some people are seriously ill and still not accessing support. And that's a big ask. It's one slide, and I think it's a huge ask, but that's the reality. And we've got professionals within the mental health sphere, both across this city and in TUV and others, who are excited by this process. And it would have a big knock-on effect. some of my ex-colleagues in policing and others. It's not just policing, there's many other aspects it would impact on. So again, we've got a prototyping process that will kick off in the autumn. And our goal is really to have a first hub up and running by the end of the year. That's the goal. What are you asked to do? And I've just got a couple of other points, and then I think I'm within my time frame. Obviously, the mental health partnership, and this is only one aspect of the mental health partnership, reports to this board. It is going to require your ongoing support, and actually active support in terms of making sure that people are released and can be released, because there's a will to do this. And this is not just me saying it because it's good to report to a board. There is a will to change, because they realise if we carry on as we are at the moment, there is going to be just significantly increased need. Eating disorders is one area. We have seen significant progress actually in eating disorders through this principle, but there is still, I'm not kidding, the unmet need in relation to children's eating disorders alone, but the change in adult eating disorders as a result of the pandemic is again probably more significant than some other areas in terms of increase. What influence you can exert over your organisations, and to say that when someone comes up, I know it's difficult to be able to release people for some hours in the autumn to do this, but without it, the situation is going to get more challenging. And it is agreed by, we have senior members in the ICS on the Connecting Our City process, and we have people who've have worked across the region. They see it as a way forward. So my final comments, Chair, are we will need to see the release of some clinicians in the autumn to work on this, because without them, you're designing something and they're at the heart of it. They're the people, and they can see these problems. It's an opportunity to imagine if we did it, what was possible. And not everything will work, but would be as it's not working and change it very quickly. Of course, we've got the change that Jim talked about. We've got new structures around us as well. But the new, we can't wait for the new structures to bed in, because these demands have been here, and the Health and Wellbeing Board's requirement are going to be partially met by the successful delivery of this. And actually, I'd say again, to finish off, this is a process that the first integration of a hub or series of hubs may take a year or so. The integration on the scale of the aspiration will take 5 to 10 years, but it would put York and potentially Derby and maybe one or two other spots in the country as a place where people could hope to do everything Jamila talked about in the dementia strategy and some. And if we don't seize this opportunity now, I don't think York will get another opportunity, because we haven't been blessed with, when we bid for finance, as several of you know, we seem to come through it despite the fact that we have need. So there's, as a board, there was an awful lot of other work going on in the Health and Wellbeing Partnership, but the fundamental thing that will drive all that will be the Connecting Our City programme and the transformation process, and the realisation that I expect to be able to walk into a hub early next year and see the first germination of a different system for this city. Thank you, Chair.
Thank you, Tim. It is fascinating. I was very pleased to go with Abby Hands, who had a big part to play in developing the draft dementia strategy, to see the possible site for a hub, and the different organisations around the table able to discuss. We'll circulate these slides, Tim. And because we haven't got Emma for the next item, I'm going to allow a few questions.
Yes, if I may say, we will also produce a comms brief to people, which can be used in organisations to say, these are the key points that you need to look at. But I would say that we've, and some of you know around the table, we took a view early on that we needed to invest in the CVS sector. We were given a minimum target for that. We've exceeded that minimum target already, because we thought we could get change more quickly and better value for money, to be frank, in the first instance. That's not about specialists and non-specialists. It was just about where we started this process. And actually, I'm grateful because we've now, I don't know if it's anything to do with me or not, we've got quite a high level of representation. And yesterday's meeting, we had over 50 people at the briefing, of which several were Lisa's colleagues at York base level.
Right, let's start with Janet.
I remember, Tim, a long time ago, Health and Wellbeing Board that we were both on.
Yeah.
You were probably doing the police at that time.
Yeah.
And you made a comment, which, do you know, I still quote to people all over the place. You said that as far as mental health is concerned, the police tend to be the place of first recall, and yet it's the most expensive system going. And I think you have gone away and risen to a challenge, because if the hub works, it should take over some of that turning up at police stations. And as you say, going into the most expensive form of access to public health services that there is. Police aren't meant to be public health services. I think the hub is a very interesting and exciting concept. I will hopefully get a chance to explore some of it more fully with you. And I shall probably grab you for a presentation to some of my colleagues, because I think this is certainly a way forward. And if Trieste can do it, heavens above, York ought to be able to do it. We put Bootham in place.
Yes.
Heavens above, we put the retreat in place. We have a reputation as very early innovators in mental health issues.
Right, let me ask Lisa if she wants to comment.
Thank you, Chair. And I'll be brief. I could speak about this all evening. I'm sure Tim could. Very, very welcome, the hub. I think an excellent and innovative means of tackling what is an increasing and very concerning pattern in York. So we have seen a huge increase in suicide, concern for safety in terms of people's mental well-being, people cyclically coming in and out of police contact as a result of the system not working for them. So the hub, I think, and the diagram on there, very, very welcome. And I can see already the benefits to many agencies, not just policing, that somebody has that stability, regardless of the stage of their journey that they are in, that they can access that holistic service. So much, much needed.
What does you say first to Councillor Looker is, yes, I was excited by the fact that there's a far better way of spending public money on individuals. Yes. But what really motivated me was that the police at the time weren't best placed to help these people. And sometimes we had the invidious position of if you remember, we were the last place in the country to have dedicated places of safety, which was absolutely scandalous. That's been rectified, and I'm delighted. The new facilities just, fortunately, it's a distant memory. But the point is, there are still people living in the city who were treated in a way, even though caringly and supportively, ended up in a police cell. So I think my main motivator, yes, there's better ways, and goodness me, there's lots of calls on money in terms of mental health. There are better ways of spending that money, but fundamentally it's about how we treat human beings and how we look after human beings. That's the key thing. And in response to Lisa, I think the issue is, the problem is that word cyclical. There are people churning through the system and desperate to try and find a way to get a hook for some sort of help and support. And it may be that they actually don't, they only go through that phase once in their lives. Well, the quicker you can get them out of that phase, but the fact that they still end up in A&E or in the sphere of policing is worrying. But I'm grateful for the support we're getting. Actually,
I'm going to bring Zoe in a minute, but I just want to say this sort of drop-in session is why I'm such a fan of talking points, local area coordinators, social prescribers. It's stop putting labels on things. People know they've got something wrong with them, and they might not know what the answer is, what the help they need is even. But if they can talk to somebody, that often brings them to a solution themselves. which is what early help and early prevention is all about.
It's fundamental. When you talked about place earlier, it is fundamentally about community and place, and then knowing, because Trieste still had seriously ill people who had mental health needs, who needed that help and direction and specialist support. But there are, as I say, we are awash, and I say we, as a southern boy who moved north about 38 years ago, we are awash with people in the city who can create positive interventions and do positive activities, which doesn't fall into the medical sphere. It may be, but it's, I don't care what it is. It can be anything from the A to Z, really, quite frankly, as long as it has a positive contribution to them.
That's why we're so lucky in this city. Zoe.
Thank you, Chair. I'm going to start with an apology because I am going to have to shoot soon. There was a terrible breakdown in communication, so I didn't get the papers before the meeting. I've been reading through them as we've been talking, and I've got a few things I want to pick up with people after the day. I especially want to speak about Healthwatch and the work and how much engagement you're getting from TUV as well. So I'll be in touch with people. Tim, I think we've got some time in soon. I have a ton of questions, very supportive in principle, but I've got lots of questions, and just want to have a chat through with you about it all. I would take up the rest of the night here in this meeting about it. So I'm not going to, but I did just want to flag with you. I am shutting off now, but we'll meet up soon.
Yeah, I think it's in the diary, so I welcome that though, because it's, I mean, fundamentally, there's a big chunk of this which sits in with you, but also doesn't sit with them. It sits with the integration between agencies in a way that often multi-agency doesn't do it justice.
And fundamentally, we recognise that. And as a point of principle, we would rather avoid people being admitted into our hospitals or getting them back out as quickly as possible. It's not the best place for them to be. And we're seeing a real rise in acuity lately and real rise in self-harm. So there's just lots to be done.
I mean, there's one fact, for example, York has a significantly high bed occupancy rate for people with serious eating disorders, far greater than other parts of the ICS and the region. And that's a significant saving. The problem is you still have to provide, can't take the bed away straight away. But that shouldn't be the case. There's something wrong with the system.
Chop you off, Tim, because we've still got Emma's report to look at. Is it short?
Very, very short. I just want to say, I think everyone knows I'm very supportive of this work. I think it is a living demonstration to us all that if our system doesn't work because people don't fit it, we need to change our system. And that's exactly what this work is about. We can't change people. We can change how we treat them. So I'm really excited to see where we go with this. And I know it's just the beginning, and it's not just about mental health. It's about modelling this for health and care.
That's right. So page 164, the 4 recommendations that Tim has put to us, which is noting the report, support the request for staff to be released, representation with the hub planning and leadership group, and notifying any key meetings. Are we all quite happy with those? Right, we are. Oh, sorry. We do have Emma's report to look at. I don't know who's going to present it as she isn't here. Who is able to actually say something about it? Sharon, are you? Yeah, thank you. Thank you.
It's really just for information, Chair, to bring the board's attention to the work of the Health and Care Collaborative. I mean, as you can see on the attachment, some of the progress on the priorities that the York Health and Care Collaborative has identified, quite a lot of progress being made on some of the key issues we identified as priorities in the health and wellbeing strategy. So smoking prevalence, substance misuse, work to tackle weight management, obesity and diabetes, aging well and frailty, mental health, etc. Quite a lot of progress being made in those areas. I think the other really positive development is the building on the success of the COVID recovery hub. that worked really, really well. And so the intention to not dissolve that hub, but to use it for further collaborative working. There is a request from the group, and really this is based on a workshop looking at the impact of deprivation on services that took place in May. The minutes of the workshop were embedded in the report, but I couldn't open them. I don't know whether anyone else could. But the York Health and Care Collaborative have said they would like to understand from the Health and Wellbeing Board where it thinks the gaps are in supporting deprived communities in York, and how we can engage the York Health and Care Collaborative in those conversations. I mean, I think the presentation we had on the draft health and wellbeing strategy earlier covers that point. And obviously the York Health and Care Collaborative will be a key group that we will continue to engage with in terms of delivering some of those priorities. So, so the report is really for information, and obviously we'll make sure that we continue to work with the collaborative as a key system-wide group.
Yes, thank you, Sharon. I think we should thank Emma and her colleague, whose name has gone out of my head, for their report. Rebecca, of course. I think we should ask for those minutes to be circulated so that we can all have a look at them. And then we can perhaps see how they tie up with what they're doing. It's quite possible that our minute taker will be able to access those minutes in the way that you couldn't, and I certainly couldn't, and get them round so people can look at them, and then perhaps we can respond to the question we've been set.
Yeah, we can certainly, or perhaps Steph, would you be able to access those minutes? If you forward them on to Tracy, Tracy can then send them out to board members. That's probably the easiest way of doing it.
That's fine. Were there any other questions or comments on the report? No, we're all quite happy with it. Okay, well, in that case, in the best traditions of this particular Health and Wellbeing Board, we're going to finish slightly early. I'm very grateful to you all for staying. I knew it was going to be a long meeting, and you know that I like to finish on time. I warn you when I'm not going to, and this meeting was one of them. So with that, I shall bring the meeting to a close. Thank you for watching if you have been. If you're going to hear it afterwards, I hope you find it interesting. And that is the end of the meeting for tonight.